Hello, doctors. How are you all? Hoping all are well. So today, my endocrinology session. Before that, I want to tell one thing that yesterday's session still not didn't updated, but it will be updated soon because some problem was working. That's why it's delaying. The PDF also will be updated, but the mock regarding those session will be take delay also. So yesterday's session recording and PDF will be take time. So today endocrinology session along with mock session and recall will be posted after the session also. And before that, I want to tell a few important highlights that what we have to know. Endocrinology question really very easy. My dear DHA, HAD, MOH, all candidates, just listen carefully that endocrinology session only thyroid. If you read strictly thyroid disease, though it will cover surgery and medicine, it will cover maximum question. Like maximum means what? These topics will cover many questions, either it from the medicine or surgery. Okay, like Hashimoto's thyroiditis, postpartum thyroiditis. So these are the medicine part. Along with if they ask regarding the surgical resection, papillary thyroid carcinoma, these are the surgery part. Though I discussed little bit more will be discussed. More thyroid question will be discussed, topics will be discussed. Because this is a very important topic for all of my exam candidates, and I emphasize more this thyroid topics. Okay. So initially, I'm starting my session regarding the diabetes mellitus. First of all, I want to tell shortly before starting my session. Kindly mute the mic. Though we know very well the basic regarding the thyroid, parathyroid, endocrinology, pituitary hormone, but shortly and to tell a little bit to be know again regarding the pituitary gland. There is adrenal gland, there is a thyroid, there is a parathyroid. So pituitary gland, thyroid, parathyroid, gonadotropin hormone, the controller system, cortisol secretion. So these are the causes for the diseases. So pituitary gland, my dear candidates, in pituitary gland you see there is the anterior pituitary and posterior pituitary. So anterior and posterior pituitary, the hormones that secreted, that we have to know from the anterior pituitary. If it is anterior, if it is posterior, just I'm discussing little bit basic that anterior pituitary secrete TSH, heart stimulating hormone, okay, ACTH, which act on adrenal cortex to control the hormone of cortical secretion. The testes, this act on the testosterone from the anterior pituitary, and ovaries estrogen progesterone. So from anterior pituitary, LS, FSH, ACTH, so LS, FSH, ACTH will be secreted from the anterior pituitary. Posterior pituitary secreted oxytocin and ADH or vasopressin hormone. Okay, posterior pituitary, ADH and oxytocin. Okay, so just for shortly, if I want to remember anterior pituitary, like pituitary adenoma, pituitary chiasma compression due to the adenoma, pituitary tumor, acromegaly, growth hormone secreting tumor. So these are the pathology because anterior pituitary secreting hormone are the most high point for my exam. So shortly, if I want to understand, its anterior pituitary is a TSH, ACTH, LH, FSH, growth hormone, and these are the LS, FSH I said already. Okay. So these are the anterior pituitary and posterior pituitary as well, ADH and oxytocin. And other hormone regarding the thyroid, the TSH is secreting adrenal gland hormone. So adrenal gland hormone are acting on the adrenal cortex medulla. So these are short brief before starting my session. So my dear candidates, very high topics for the exam: diabetes mellitus complication and the management. Okay, so diabetes mellitus, a patient come to my hospital with polyuria, polydipsia, polyphagia, weight loss, tiredness. These are the presentation of blood vision like that way. So diabetes mellitus symptoms, and we have to do the blood sugar test with one abnormal value. So one abnormal value with diabetes symptoms, diagnosis, you have to do diagnosis by, or two abnormal reading of fasting blood glucose on two separate occasions. So these are the way we have to do diagnosis the diabetes mellitus. Actually, kindly mute the mic, my dear candidates. There's echo. So plasma glucose level normally random will be the below 11, pre-diabetes non-detectable, but the diabetes range will be the more than 11. It is the diabetes range. If random, we have to detect if patient's sugar level more than 11, so we have to tell it is the diabetes. So fasting blood glucose level normally below 5.5, pre-diabetes level very important 5.5 to 6.5, and if it is diabetes, it's a more than 7. This chart very important for our exam, pre-diabetes and diabetes. 2 hour postprandial OGTT test we have to do to confirm the diagnosis. Pre-diabetes, it will be the 7.2 to 11, and diabetes more than 11.1. HbA1c very important. It's a normal is 6%. In exam, they preferably give millimole value. Okay, so best to remember both. Though they give normal value, but this 48 6.5% is the diabetes. Pre-diabetes is a 6 to 6.4. It is a pre-diabetes value. So this way we have to keep remember the lab value for the diabetes mellitus. My dear candidates, impaired glucose tolerance, my DHA candidates, they ask FBG level is below 7. It's impaired IGT. OGTT will be the 7.2 to 11. Both value they give and they ask what is the diagnosis. We will practice more question today, inshallah. HbA1c is preferred in case of uncertainty. Actually, many candidates I saw and I observed that before OGTT they are selecting HbA1c. No. If fasting more, we have to do confirm by this way. To abnormal reading of fasting blood sugar on two separate occasions, diabetes symptom or one abnormal value or with OGTT test. HbA1c value later part, very later part. Okay. So if HbA1c is still, so see what they said. HbA1c is preferred in case of uncertainty. Fasting plasma blood glucose test is preferred. Fasting plasma blood glucose preferred in end-stage renal disease. OGTT test is no longer recommended. They said no longer recommended, but for our UA exam, it's a guideline. They didn't recommend it. They prefer HbA1c, but in an UA exam, all recall after FBG, we have to give OGTT. But if in your option OGTT not stay, mark HbA1c. These are the exam recall. Many candidates prefer they stay both HbA1c OGTT. For our exam, we have to select OGTT, though they say this is not longer recommended diagnostic for standard for the gestational diabetes. So gestational diabetes, OGTT is not diagnostic value, it's the gold standard. So remember this way, OGTT is not longer recommended for the diagnosis of diabetes mellitus. However, it is a gold standard for the diagnosing gestational diabetes mellitus. So exam question, what they are asking? They ask if FBG high, next is not HbA1c. No. So you can ask me, ma'am, it's not gestational, it's normal. Normal, but see the option. HbA1c in option and OGTT in option. Because we have to go proceed our exam wise answer. Though we are the clinical, mashallah, we are sharp, but basically they prefer after FBG OGTT. But in case of gestational, there is no doubt to mark OGTT, but the regarding the HbA1c and OGTT is the confusing. So best to mark OGTT. If it is not stay in the option, mark HbA1c. HbA1c relates to mean glucose level over previous 8 weeks. So it gives the value for the 8 weeks value. HbA1c give value is the 8 weeks value and it's the 48 to 57 millimole. Patient on dual therapy. Okay, so a patient in hospital, you are giving metformin and sulfonylurea. Our aim of the HbA1c exam question, our aim is below 53. Okay, so below 53 means what, my dear candidates? Below 50 means below 7.5. Okay, below 7.5. This is the target value if it is dual. Though the stepwise management I'll discuss. Treatment. First of all, I will give the metformin. If HbA1c is still more than 58, this is the stage. Strongly remember, and you have to choose accordingly. Exam question. If it's still more than 58, dual antitherapy you given, and still 58, you have to give triple therapy. Like after metformin, we give sulfonylurea, glypinazide, okay, glympuride. But it's still more than 58. So we have to add DPP4 or SGLT2 inhibitor. So these all will be discussed. So remember, dual therapy we given still persistent, so triple therapy. But in bad kidney, renal impaired patient, we can't give MS, means what? We can't give metformin, sulfonylurea and SGLT2 inhibitor. We can't give. In cardiac patient, we can't use DPP4, glucagon. Cause why? Exam question. Why we not use DPP4? Cause it cause water retention. That's why we avoid it. Cause pulmonary edema, water retention. That's why we avoid DPP4, glucagon. Okay. So CKD patient actually just remember metformin. Sulfonylurea and SGLT2 inhibitor is not our concern. Exam wise, we have to remember metformin. Side effects of oral hypoglycemia is a very important exam question. My DHA candidates, lactic acidosis complication for the metformin. We have to remember this way. Weight gain from the glucagon is a recent exam question. Glucagon glycoside. Weight gain. These are the complications. They give this drug name and you have to remember this GG. Glucagon and glycoside. Glucagon is a DPP4. Glycoside is a sulfonylurea. Sulfonylurea glycoside, glibenclamide, it causes commonly hypoglycemia. Patient come to your hospital with hypoglycemia. You are not understanding, unconscious patient. You are seeing the sugar level is very low. So it's the what's the drug? Either you have to take the history, patient taking sulfonylurea. Glucagon, common complication, bladder cancer, glucagon, exam question. So from there, many exam question I discuss. Complication from the weight gain, HbA1c, treatment management wise, okay, stepwise management, DPP4, sitagliptin cause pancreatitis. So my dear candidates, keep focus these topics, very important for the exam, okay. Hypertension management, already we are very expert in this regard. The DM with AKI or CKD, we prefer AC inhibitor because AC inhibitor is a renoprotective. Any age, but patient diabetes, we have to choose AC inhibitor as a renoprotective because it decreases nephropathy. Okay. Black Afro-Caribbean is not our concern, though we choose AC inhibitor, neither we can give CCB. Just remember, any age, patient diabetes, whatever the age, it's a 55, 65, though our protocol below 55, more than 65, below 55, more than 55, but for the diabetes, this protocol will not be used. Okay. So, any age we have to give prefer that AC inhibitor. Complication, macrovascular complication cause what? My dear candidates, cause death like MI, stroke, cerebrovascular accident. Okay. So complication exam question, deloxetine. Where we use deloxetine? Pregabalin. Dr. Saba, where we use pregabalin in diabetes patient?
Yes, ma'am.
Indication of deloxetine in diabetes mellitus, where we give deloxetine or pregabalin. Is the
Ma'am, when there
pregabalin.
is a nephropathy, then we will use the
Neuropathy.
neuropathy. Yes, ma'am.
Tingling, numbness sensation.
Yes,
Patient
ma'am.
long-term diabetes mellitus.
When the
Okay.
patient is diabetic mellitus and having a long-term history, then we will use the pregabalin and gabalin for the neuropathy. Tingling
Yeah.
sensation and the numbness, and also, ma'am, sweat hands, etc. For these purposes.
Yeah. Excellent. Excellent. Yeah, they are. Yes, you are right. So DKA acute management, they ask how we manage DKA management. Hyperglycemia, hyperosmolar state, hypoglycemia. So triads. There's a triad hyper and hypo. Along with the hyperosmolar state, we see ketone body. in DKA patient. Okay, chronic complication retinopathy, we have to do follow-up 6 monthly or yearly according to the complication. Type 1 diabetes mellitus, type 2 diabetes mellitus patient, nephropathy, neuropathy complication, and macrovascular complication, AMI, accelerated atherosclerosis, stroke. Okay, so these are the complication, very important. We have to know the management. So DK exam question, my DHA had emerged. Can I just remember very carefully? Precipitating factor, DKL, like a patient come to my hospital, either patient MI or after infection. Actually, commonly who are we working in the ICU, CCU? After MI, commonly the glucose level become 28, 30. Why? Due to stress. MI itself causes muscle necrosis. This causes stress and increasing cortisol level. That's why causes hyperglycemia. So these are the precipitating factor. Presentation will be the dilation, Kussmaul's breathing, ketone will be the positive, acidosis. So it's a metabolic acidosis. So they'll give the ABG interpretation, metabolic acidosis, bicarbonate level, pH value. Okay. So we have to interpret this way. And diagnosis must, this diagnosis trials we have to remember strongly. How? Diagnosis is that hyperglycemia, we have to tell if sugar level more than 11, if bicarbonate level below 15, if pH value below 7.3, ketonemia if more than 3. So ketone exam question, after detecting sugar level 2028 and there's a bicarbonate below 15, what you will do next? We have to check ketone body. Okay, management exam question, very important management. I'll discuss and I'll take more question later. Just there is a large topics we have to cover. That's why I'm telling. And if anyone difficulty to understand any words, just ask me by raising hand. So diabetic ketoacidosis, if systolic blood pressure below 90, it's a 1 liter 0.9% sodium chloride over 10 to 15 minutes. So blood pressure is our main issue. Just remember exam question, initially how we will manage DKA patient. We have to start infusion 0.9% normal saline. If below 90%, within 10 to 15 minutes, it's a bolus. We have to give bolus. If it is more than 90, we can give within 1 hour. Then we have to start insulin therapy by insulin infusion pump over hour via IV fluid. Okay. So IV fluid over hour, we have to give this insulin. Just remember, when glucose will be below 12, we have to start dextrose with insulin to keep balance. Okay, cause it may cause hypokalemia, so we have to check again potassium, cause if needed we have to give potassium supplementation. Patient presentation may be like that. So ABG interpretation, abdominal pain, vomiting, these are the patient presentation. Hyperketonemia leads to exertional ketone body. Okay, sodium bicarbonate, we have to see if it is sodium bicarbonate more metabolic acidosis, it goes towards cerebral edema if we do rapid correction. So we can't do hurry for this correction. Okay, because it causes cerebral edema. So hypoglycemia considered when blood glucose below 4. Cognitive function deteriorates when below 3 millimole per liter. So sweating, so hypoglycemia presentation we know very well. The causative or precipitating factors are the liver failure, insulinoma, insulin sulfonylurea, alcohol, commonly alcohol. Diagnosis, we have to check capillary blood glucose. So we have to stepwise, we have to remember the precipitating factor. Hypoglycemia. So hypoglycemia, if patient conscious, no. So patient, we have to recover the position, clean the airway, call for the help. Okay, and according to the patient conscious level, is it cardiac arrest or only we have to check the capillary blood glucose level. Neither we can give orally fructose or IM glucose. Okay, administration. So these are the chart we have to remember. So patient can't swallow. Patient can't swallow, so we can administer 10% glucose 200 millisecond over 1 milligram glucagon IM or subcutaneously. If patient not conscious or can't swallow, but if patient can swallow, we can give fruit juice. Okay, this way. So hypoglycemia management, just they asked directly my DHA emerge candidates that if can swallow, how will manage, or if not unconscious can't swallow, how will manage. Management diabetic preoperative complication, preoperative therapy. Just remember, if minor surgery, we can give only orally controlled. So normal regimen, there is no need to be stopped before that. Like major surgery, we have to omit long acting hypoglycemia preoperatively, monitor blood sugar every 4 hours because it's a major surgery. If needed, insulin control commons, if IV insulin sliding scale. So it's a major surgery. But for in the minor surgery, there is no concern. Just we can give follow up and orally anti-diabetic drug we can continue. My dear candidates, DPP-4, sitagliptin plus pegloticin, all oral hypoglycemic drug can continue as regular dose. But in case of contrast, like we are doing angiogram or CT contrast MRI, we have to stop metformin. But DPP-4 or PM pegloticin, it no need to stop. But metformin 2 days before any surgery or contrast dye, we have to stop 2 days before or restart after drinking. Or if actually another way, how we prevent contrast induced nephropathy. To prevent contrast induced nephropathy, like in angiogram, MRI, CT scan, if contrast used, we have to continue infusion normal saline 24 hours to decrease the contrast induced nephropathy. Okay, so this way exam question they ask. Okay, sliding contraindication bigonide. So contraindication of metformin, we have to remember the severe infection, actually EGFR level we have to remember strongly. If it is below 30, we have to stop metformin, we can't give metformin. BMI more than 30, so means obese. We have to start bigonide, but no, EGFR below 30 we can't give. So in kidney patients, safe drug sitagliptin is a kidney protective, neither we can use insulin. Okay. Risk factor modification of diabetes mellitus. So as already I discussed regarding lipid profile, we have to see the LDL level. Just shortly I can start this lipid profile important. Primary prevention, 10-year cardiovascular risk using CRISC 10%. A CRISC risk factor, most type 1 type diabetes mellitus, high cholesterol, age more than 85. So these are the risk factor for primary prevention. Like a patient, you done risk factor is more than 10%. So risk 10% means we have to start atorvastatin, rosuvastatin. Okay. Another way, if patient type 1 diabetes mellitus, there's chance of having atherosclerosis or patient develop hyperlipidemia, high cholesterol, or age more than 85, or CKD patient, EGFR below 60. So these are the classification in which we have to start primary prevention by guanine or by giving lipid or anti-lipid drug or atorvastatin or rosuvastatin. Okay, secondary prevention, like in the heart attack, heart disease, stroke patient, we have to peripheral arterial disease, we have to start this 80 milligram atorvastatin. So these are the categorized worst risk factor modification in the diabetes mellitus. Actually, in diabetes mellitus patient, commonly we don't use antiplatelet other than MI or cerebrovascular accident, neither no need. Okay. So this question, these topics I'll discuss later. Before that, just I want to discuss few questions. Though is it till now what we discuss or not? Just for discussion. Question will be broad, but try to understand. Okay. Okay. This question will be discussed with me, Dr. Kishori.
I'm here.
Yeah.
Okay, 45.
Is that
45.
readable? Is
Okay,
that
ma'am.
okay?
Okay, ma'am. Okay. 45-old man is referred to the acute medical unit. He had presented earlier in the day to the GP, complaining of ongoing fatigue and polydipsia. Finger prick glucose taken in the surgery was 22.3 millimole per liter, and on examination he is obese. BMI is 36 kg per m squared with a pulse 84 and blood pressure is 144 by diastolic is 84 and blood tests reveal the following: sodium is 140, potassium 3.9, bicarbonate 23, urea 5.2, creatinine 101, glucose 21.2. You encourage him to lose weight and discuss basic dietary advice. What is the appropriate initial management? Glyclazide, piclitagen, exendin, and metformin commence insulin therapy. I recommend him, ma'am, option 1.
Glycazide.
Yes, ma'am.
Dr. Kishori, your scenario, what are
Ma'am,
the point you will tell? Yeah,
okay,
1, 2, 3. Yeah, tell me 1, 2, 3, ma'am. These are the scenario.
his renal creatinine is also high, 101. I
It's a
think,
101 is not. It's a high. It's a normal
yes.
level. It's not high. Creatinine normal level is 120 micromole. So it's a 101. So till 120 is acceptable. It means 0.8. It's creatinine. It's
0.8. Okay, 0.8. Okay. Glucose 21.
No,
Without
I am
AV.
asking Dr. Kishori, as you mashallah doing well, just tell me, ma'am, these are the point and I am thinking this way. Just read the scenario again, because this is not so easy, but you have to think this way. Okay? Think again.
Ma'am, he already the surgery done
Mhm.
because he was taken in the surgery. I think this is this is not post-operative, this is pre-operative.
No.
22. His
Dr. Kishori, first of all, here important point is that whatever the surgery, patient ongoing fatigue,
fatigue
polydipsia means it's
and
not,
polydipsia.
it's ongoing, means you are the doctor, you check sugar, it's 22. I am telling that okay, doctor is 22, but BMI high, okay? And you see, you are doing the glucose level which reveal 21. So it's still persistently high. Random blood
Yes.
sugar, our level is below 11. It's a 21, 20. So it's a more than our expected level, and all decision goes toward that patient is obese, BMI is high, patient persistently hyperglycemia is not due to the surgery, because surgery hyperglycemia I'll discuss later that it persists a few hours and it resolves. Stress induced. If you ask me, ma'am, it could be the stress induced, but no, cause this patient persistent BMI high and ongoing means, if you asking how will you facing any frequent mutation, frequent thirsty, and I am telling I'm your patient, yes, I'm feeling like that, frequent micturition, frequent thirsty. So I am categorized on diabetes mellitus. So what is the drug of choice initially, Dr. Kishori?
Ma'am, initially we give metformin.
But the category is patient BMI. I discussed this topic. That's why. That why metformin first? If patient BMI high initially, we have to detect, because patient never diagnosed case. No. Patient recently as admitted to your hospital for surgery purpose, and patient persistently hyperglycemia is not stress induced, and you are taking history, patient telling, yeah ma'am, I'm facing this. So all goes towards the diabetes mellitus new onset. So you have to started the medication. So this medication patient wise is the choice of drug is what?
Metformin.
Metformin. Clear?
Yes, ma'am. And
Met
ma'am, is there
Mhm.
okay, ma'am? Is there PS value, ma'am? Is it metabolic acidosis case?
Okay, where is metabolic? I didn't see any. Sodium is 140, potassium is 3.9,
Okay.
bicarbonate 23 normal level, urea 5
Yeah.
point normal level, creatine 101 normal level, only glucose high.
Okay. Okay, ma'am.
It's not DKA. Okay, okay,
Ma'am.
clear,
Thank you.
Dr. Kishore?
Yes, ma'am.
There is nothing P as
Yes,
well,
ma'am.
only glucose high. So see the description. This way they ask common exam question, metformin. Why metformin is a biguanide used mainly in the treatment type 2 diabetes mellitus. It has a number of action to improve glucose tolerance, number of action. Unlike sulfonylurea, it does not cause hypoglycemia, weight gain. So sulfonylurea itself causes weight gain. Or still patient persistently obese. So I can't choose sulfonylurea this kind of patient. So here, in case insulin sensitivity is the choice of drug metformin. So some hypercalcemia, this is the very important topic for the exam. So hypercalcemia, very important topic, they ask commonly management. Though we know very expert, just remember, patient come to me hospital, painful bones, especially seen in primary hyperparathyroidism. Primary hyperparathyroidism, painful bones, constipation, pancreatitis, vomiting, nausea. These are the bones. So what are the manometers? Bones, gones to bones. Bones means psychiatric, bones mean abdominal, stones mean renal stones, bones mean bones pain. So bones, these are the mnemonics. We have to remember this way. Bones means constipation, GIT problem, meningitis, vomiting, nausea, psychiatric. Bones mean lethargy, easy, fatigue, depression. Cause of primary hyperparathyroidism, my dear candidates, exam question, malignancy, multiple myeloma, sarcoidosis, my MOH candidates, very high yield topic sarcoidosis, hyperthyroidism following immobilization, thyroiditis. They ask thyroiditis causing for the hypercalcemia. These all are the exam question. Just directly they ask regarding the multiple myeloma, sarcoidosis, and the drug causes hypercalcemia. Can't forget, just strongly remember this way. Hypercalcemia, just remember the causes. It could be the primary hyperparathyroidism, hyperplasia adenocarcinoma, secondary hyperparathyroidism, vitamin D deficiency, decreased calcium intake, chronic renal failure. Exam they ask chronic renal failure, secondary hyperparathyroidism. So hyperparathyroidism, tertiary, primary, secondary was, we have to remember primary. If there's adenoma, we have to do surgical resection. If it is autoimmune condition, so we have to do autoimmune management regarding the primary hyperparathyroidism. PTH independent, parathyroid independent hypercalcemia, we have to increase intake of calcium and vitamin D, and we have to treat accordingly PTH dependent hypercalcemia. My exam question is hypercalcium management. We have to start immediately normal saline to increase urinary excretion. Furosemide dichromate to increase calcium excretion. Exam question. Bisphosphonate exam question. Ozolendric acid we have to use to decrease or to reduce bone resorption. Denosumab to reduce bone resorption. So my dear candidates, these all are the high topics for the exam. Treatment wise, they ask commonly from the bisphosphonate. Acute setting hypercalcemia, we can give the infusion normal saline, but for the chronic case hypercalcemia, we have to institute or we have to start it bisphosphonate. Okay.
Dr. Ayan, sorry to
Yes.
interrupt you. Can you go to the previous page?
Yeah,
That
Dr. Mani.
hypercalcemia. Yeah, can you go to the previous page, hypercalcemia? There is telling parathyroid independent hypercalcemia will increase intake of calcium. We will increase
And
intake or we will reduce the intake of calcium.
PTH independent hypercalcemia, Dr. Monia Jaman, just remember PTH dependent or independent is not my fact. Fact is that if anyone intakes calcium more or vitamin D exposed more, what is caused? Toxicity. Okay.
Yes.
So it is not PTH dependent, it's independent, means you are taking more calcium. If you stop
Okay.
it, it will be resolved. It is independent, means you are taking, you are getting more. Okay. Malignancy, like you have a cancer, this calcium are raising itself. It is not thyroid gland or parathyroid gland related. It's not. You have parathyroid gland above the thyroid gland.
I
So
thought this
this
is the
is
treatment. Sorry, I thought this is the treatment because I know we have to reduce intake. I thought they're telling to take
no, no,
if
no,
you have
no, no, no.
hypercalcemia, we
It's
have to take. Sorry, sorry, sir. Now I understood. I mean, they're telling one reason is primary parathyroid hyperthyroidism. Another reason is this one, that independent hypercalcemia. Okay, I got it. I thought this is the
these
treatment.
are the
I'm
these
sorry.
are the these are the cause.
Reason,
Okay.
causes. Okay,
These
okay,
are
okay.
the cause. These are the cause. Yeah.
Thank you, thank you. Sorry to interrupt you.
No, no, it's okay. It's okay. If anyone not understanding, just unmute them. I can ask me, no issue. So hypocalcemia, my dear candidates, hypocalcemia manomis is cash go numb convulsion. Arrhythmia is one. Hypocalcemia cause what convulsion? Tetany-like presentation. Carpopedal spasm. Exam question, they are telling the patient come to hospital with this is the carpopedal spasm, or they'll give this paresthesia, finger toes, perioral, paresthesia, tingling numbness. So it's the hypocalcemia causology. Hypocalcemia causology, just remember few surgery question that acute pancreatitis picture, but they are giving hypocalcemia. Don't be confused. Even if you don't see this calcium level, it's okay, it's acceptable, because hypocalcemia is a complication of the pancreatitis. Even hypercalcemia itself cause pancreatitis. So best in surgery, no need to see regarding the calcium level, because we have to treat according to the management of the pancreatic picture. That's why this is the very many candidates do wrong. So just remember causology for my hypocalcemia, parathyroid dissection, or if you done surgery, okay, or any kind long-term complication, metastasis. Even we know metastasis itself cause hypercalcemia, but it can cause hypocalcemia. So when they are giving a metastatic picture, you are seeing hypocalcemia, don't be confused, because metastasis itself can cause both. Okay. High PTS value. So see, high PTS value cause vitamin D deficiency. Even if it is resistant, it cause pseudo hyperparathyroidism. Okay. Hyperventilation. Hyperventilation in psychiatric question you can get, and it cause hypocalcemia. Exam question: Bostic sign and Trousers sign. Tapping facial nerve and carpopedal spasm following blood pressure, cough, inflation. They'll give this positive sign and they ask what is the diagnosis. Prolonged QT interval, hypocalcemia, Bostic sign, Trousers sign. They ask commonly my DHA candidate. It's the hypocalcemia. Symptomatic management. Initially DHA candidates exam question, we have to manage by IV calcium gluconate. Long term oral calcium supplementation. Just remember calcium gluconate. That's it. Hyperparathyroidism question, my dear candidates, listen very carefully. Causology. Causology for primary, it's I already discussed parathyroid adenoma, hyperplasia carcinoma. This lab value very important. Calcium will be higher, phosphate will be lower. This is the lab value they'll give, and you have to do understand the is it primary, secondary, or tertiary. Man 1, man 2 a question is not our promoting exam question, but shortly I want to tell 2 to 3 words. Man 1, man 2a. Man 1 means multiple endocrine neoplasia. Multiple endocrine neoplasia means what? It is due to the insulinoma, means insulin gland. There is a benign tumor. It can be glucagonoma. It can be papillary medullary thyroid carcinoma. So man 2A, it is related to medullary thyroid carcinoma with hyperparathyroidism. Man 3A, medullary thyroid carcinoma, hyperparathyroidism along with neurofibromatosis picture or cafe always both picture. So though this is not our concern in exam, they don't ask, just don't remember. Remember that primary hyperparathyroidism associated with man 1 and man 2, that's it, and treatment is surgery. Because this is the vast topics you have to remember. No need to remember, just remember primary hyperparathyroidism associated with man 1 and man 2. Secondary hyperparathyroidism, CKD exam question or associated parathyroid hyperplasia due to long-standing hypocalcemia. So the lab value will be the hypophosphatemia and low calcium level with hyperparathyroidism. Treatment is calcium, vitamin D. A CKD patient commonly in what we are giving calcitrol, calcium vitamin. Okay. Tertiary hyperparathyroidism, autonomous production parathyroid hormone following long-standing CKD. So these all value will be had tertiary. Just remember, autonomous means spontaneously producing. Surgery, definitive management, or we can give calcit. Primary hyperparathyroidism. C. If parathyroid hormone increases, reabsorption calcium from kidney but excreting phosphate, so it will be the low. Bone resorption which increase serum calcium level and calcium are resorbing in the intestine causes production of activated vitamin D. So actually primary hyperparathyroidism, as it is caused due to the adenoma, we have to do surgical dissection. Primary hyperparathyroidism, PTH increased calcium is increased phosphate decrease. These are the value. Just remember the pictures: hypercalcemia, moles, bones, moles. Okay, and PTH value cause osteoporosis and fragility fracture. These are the complication. We have to remember primary hyperparathyroidism. Calcit initially, though it's a surgical management, bisphosphonate if there is a hypercalcemia to reduce the fragility. Parathyroidectomy is the definitive management, very important stepwise management. So regarding the history, kidney stone, bones and the stones and fragility fracture, laboratory evidence, hyperparathyroidism, and we have to do parathyroidectomy. If any presentation, fracture and kidney stone, we have to do this. Secondary hyperparathyroidism, my dear candidates, I said is associated with CKD. Okay. Treatment, vitamin D supplementation, cholecalciferol. The exam, my dear emerged candidates, SLE candidates, we have to remember vitamin D supplementation, treat vitamin D by cholecalciferol or alpha calcitrol, treat vitamin D in patient with severe renal impairment. They ask these drugs tests, so don't be confused. In CKD patient, we give cholecalciferol or alpha calcitrol. Okay. If calcium low, we know very well that we have to do calcium supplementation. As phosphate level is high, so we have to give phosphate binder. Secondary hyperparathyroidism, my dear candidate, just remember very carefully. Secondary hyperparathyroidism associated with CKD, but always these are the causology. Secondary hyperparathyroidism. Now diabetes mellitus already discussed. Just shortly, type 1 diabetes mellitus is the family. Insulin insufficiency means what? It's not due to that any insulin resistance like type 2, no. Obesity, family history, gestation, no. Type 1 diabetes means deficiency, can't, pancreatic and not in functioning. Pancreas can't secrete insulin, so we have to give external insulin. Type 1 diabetes mellitus patient. Exam question, type 1 diabetes mellitus, how we will manage? We have to manage by insulin. We can't give oral hypoglycemic agent because there is no beta 1, beta 2 or any receptor for acting. So we have to give externally insulin. Okay. So this way we have to remember. Diagnosis, as we already discussed that regarding the SMT, fasting blood sugar, HbA1c level or OGTT level, insulin therapy, type 1 diabetes mellitus, type 2 diabetes mellitus, metformin. So we have to do the HbA1c level, we have to keep management. So type 2 diabetes mellitus management. So C, stepwise management, already I discussed. Just remember metformin first, then and recheck HbA1c 3 to 6 monthly. So you have to check if it is higher. So reinforce lifestyle modification along with the diabetic drug. I said stepwise management already. I discussed 2 then 3 this way. Diabetic ketoacidosis shortly I discussed, but regarding the HONC, hyperosmolar, my DHA Candidate's recent exam question, HONC, hyperosmolar hyperglycemic acidosis or HONC is said type 2 diabetes mellitus complication we have to treat by only electrolyte correction and by 0.9% normal saline to correct this glucose level and to reduce the plasma osmolality. So now question practice. First question will be discussed by Dr. Sajma. First one.
Yes, ma'am.
Yeah.
28-year-old pregnant lady underwent for her OGTT and it was positive and diagnosed as gestational diabetes. What will you do next? Repeat GTTT, do random blood glucose, do insulin tolerance test, start her on diet. Yeah. The right option will be option D, start her on diet.
Why?
Ma'am, for gestational diabetes, initially we give dietary modification strictly. Secondly, then we'll, if it doesn't control on diet, then we'll add on metformin.
Metformin. Okay, excellent. Excellent, Dr. Sajma. Thank you. Second question will be discussed by Dr. Sneha Raj.
Yes, ma'am.
Yeah. Second question.
Patient with type 2 diabetes mellitus has conservative management, still complaining of weight gain and polyuria. Give insulin short-acting, metformin, long-acting, or none of the above. So, ma'am,
Dr.
this patient,
Sneha, yeah, tell me the
he
clue.
has,
These are the clue, ma'am. I am thinking this.
so this patient already is having diabetes mellitus, and he was probably on a dietary management, but he's still complaining of weight gain. So it is still an unprocessed diabetes. So I think it is best to start him on metformin. That's the first line of management, as well as that will help with the weight gain also.
Okay, to reduce the weight also, it will help both. Okay,
Yes,
right.
ma'am.
Thank you, dear. Thank you. You done well. Third question will be discussed with me, Dr. Shruti. If Dr. Shruti is not here, then third question will be discussed with me, Dr. Hira.
Yes, ma'am.
Yeah.
35 years old woman consults an ophthalmologist because of double vision and droopy eyelids. She also has complaints of generalized muscle weakness. IV injection of endocrine dramatically but only briefly reverses her symptoms. This patient, ma'am, I cannot see it. Can you make it back?
Okay. Okay, you can see. So say you said that it's a reverses her symptoms. Till now you read, right? The patient's okay, probable
Yes, ma'am, now I
disease
can read.
has
This
a
patient,
pathophysiology.
this patient's probably disease has pathophysiological basis that is closest to that of which of the following conditions? A.
Bullous
Bullous
pemphigoid.
pemphigoitis, B. Diabetes mellitus type 1, C. Idiopathic Addison disease, D. Insulin resistance. Ophthalmologist, double vision, droopy eyelids, muscle weakness, IV injection of endocrine dramatically, but only briefly versus the symptoms. The patient probably disease with following condition. Ma'am, it's not
First
A.
of all, okay. Tell me.
Ma'am, it's not A.
Patient is 35. Is there any possibility type 1 diabetes? Age 35.
35. No, ma'am. It's not
No, ma'am.
possible type 1 diabetes mellitus. Yes.
Okay. Strongly said or doubtly said?
Not confirmed, madam.
Okay. So, it's strongly it's not. Because type 1 diabetes mellitus within 18. So, it's a 35. So, it's a Khalas, it's avoided, it's closed. Then idiopathic addiction. Is there any possibility of having addiction? Hello? Is that my voice is clear, my dear candidates, or any problem?
It's clear, ma'am.
Ma'am, clear.
So is that problem from the data Hira's net maybe? If so, this question can be discussed by another candidates if Hira's network problem facing problem. So Dr. Ifada.
Yes, ma'am.
Yeah, discuss this question.
Mm, these 35 years old women consult an ophthalmologist because of double visions and droopy eyelids. She also has complaints of generalized muscle weakness. IV injection of endorphinium dramatically but only briefly reverse her symptoms. This patient's probable disease has a pathophysiological basis that is close to that of which of following condition: A. Bullous pemphigoid, B. Diabetes mellitus type 1, C. Idiopathic Addison disease, D. Insulin resistant. I think this patient uh, relate with the diabetes mellitus type 1.
Why 35-year? Is there any possibility of having 35-year type 1? The
Uh,
age, hello, no. No possibility. Okay. So what is
okay.
the cause? First of all, what they said, my dear candidate, is a LADA means lateral. If it is in elderly, it's not elderly, it's like after 55. Before 18 to 35, till 18 is a type 1. Before then till 18 to 25 or 35 is a type 2. No, it's after 35 it can type 2, but before it is LADA means late onset type 2 1 diabetes mellitus. So in LADA case that causes what? One A option bullous pemphigoid is cross. It's not. Then
Yes.
type 1 diabetes mellitus is cross. No. There is no presentation of addition. No presentation. Generalized muscle weakness, IV injection, hydro. Uh, this is the nephrium is dramatically given. This reverse the symptoms. So what does it mean? It means patient become hypoglycemic. So you give the hydromorphium. So it's a cause dramatically improve and reverse the symptoms. So what we have to do? Why this causes? Due to the it's a type diabetes mellitus. Patient have diabetes mellitus. That's why patient presentation is like that due to the why. This diabetes mellitus is due to insulin resistance. Okay, it's due to the insulin resistance. It's a type 2 diabetes mellitus, not type 1 diabetes mellitus. Clear or not?
Yes, clear, ma'am.
Yeah. You even if I always say even if you can't understand the answer, just do excluding method. No possibility of having bullous pemphigoid, not possibility. You given this hydromorphium dramatically response means what? Endrophonium itself. So your patient come to hospital with double vision, droopy eyelid, and complaining of general muscle weakness, and endrophonium dramatically improve, brisky reflex, reversal symptoms, so all goes towards means what? Droopy eyelids was goes towards is the myasthenia gravis, right? Double vision. So you give androphonium, it goes towards the myasthenia gravis, and its pathophysiology is now is the reverse the symptoms also is due to the patient develop this hypoglycemia, double vision, there's an autoimmune disease. So this way we have to think is a type 2 diabetes mellitus pathophysiology is due to the insulin resistance. Okay, no issue, Dr. Hira. So insulin resistance is the answer. So diabetes, thank you, Dr. Ifada. You tried, and actually question is indirect question, autoimmune disease, endorphin you giving, and now patient presentation dramatically improve. It is due to the both autoimmune disease, endophenia also due to the, we have to manage in acute setting. Okay, diabetic nephropathy, always exam question they ask towards that, how we manage diabetes nephropathy. We have to manage diabetic ketoacidosis, already we discussed, but the question was diabetic nephropathy. So diabetic nephropathy, proteinuria, microalbuminuria treatment is AC inhibitor to prevent progression. Increased risk factor for the cerebrovascular disease due to the improper glycemic control. We have to give statin to decrease this atherosclerosis. Chronic complication already discussed regarding the nephropathy. So globe stroking pattern, burning numbness sensation, and we have to tight glycemic control. And this diabetic food complication, gangrene, smoking cessation, own management. If there is ulcer, food inversion to prevent the ulcer formation, such as well-fitting footwear, we have to do advise the patient. These are the chronic complication of the diabetes mellitus. So diabetic ketoacidosis already I discussed. So diabetic ketoacidosis patient come to my hospital with polyuria, polydyspepsia, dehydration, type 1 diabetes is a common causology for the type 1 diabetes mellitus, which causes diabetic ketoacidosis. The signs are the hypertension, tachycardia, precipitating factor already I discussed. So this last question will be discussed with me. I don't know what happened today. Just frequently these are ongoing. Okay. So last question will be discussed with me, Dr. Renata.
Hello. Yes.
Yeah.
Diabetic patient come with DKA, what is most common case? Diet mismanagement, insulin mismanagement, stress, none of the above. I'm
So what they
think
ask, what does diabetic patient come with DKA? Your hospital, you are doctor and you found this is the DKA patient. So what is the most common cause and how you will manage? What is the most common cause and how you will manage?
I'm thinking the answer should be B.
Why?
From my opinion, it's the most common case of DKA.
So what is the most common case and we have to manage by DKA by, if insulin mismanagement, I ask what is the most common cause, mismanagement also common cause. But if I ask Dr. Renata how you will manage, tell me one word for management. Though this
Insulin.
is not, no. Insulin we give with, first initially we have to give normal saline.
Normal.
We have to, okay. Then we have to manage hyperglycemia. Though it's insulin management, hyperglycemia, my patient, but initially I said one word, never forget normal saline, and accordingly, second step is insulin, and third stage is dextrose insulin, and fourth stage is potassium management. Clear?
Yes.
Renata, done well.
Thank you.
Second question, yeah. Second question by Moshumi, Dr. Moshumi, second question. If Dr. Moshumi is not here, second question will be discussed with me.
Yes, ma'am, I'm here.
Dr. Moshumi is here, right?
Yes, ma'am.
Mhm.
Patient known case of type 2 diabetes mellitus on
Your
insulin.
voice is not clear, Dr. Moshumi. If you able, you can loud your speaker.
Patient known case of diabetes mellitus type 2 on insulin. His blood sugar measurements are following: morning 285 milligram per day at 3 p.m., 165 milligram milligram per dl. At dinner time, 95 milligram per dl. What will be your management? Increase evening dose of long-acting insulin. Decrease evening dose of short-acting insulin. Decrease evening dose of long-acting insulin. Increase evening dose of short-acting insulin. Average morning blood sugar is 85 milligram per dl. Increase evening dose of long-acting insulin.
Your answer is
Increase evening dose of long-acting insulin.
increase evening dose of long-acting insulin. Why?
Because morning blood sugar is 85 milligram per dl. Yeah.
Morning and noon both are higher, so we have to increase evening dose of long-acting which cover all, right? Which cover all. Clear? If we increase long-acting insulin, it will cover morning and noon sugar level also, like 3 p.m. 165, morning 285. So I have to increase long-acting, which work 24 hourly. If I increase long-acting, I don't have any headache regarding the short-acting. I have to increase the long-acting insulin, so it will cover morning and noon sugar level. Clear?
Yes, ma'am.
Yeah. So third question you will be discussed with me, Dr. Badhon.
Yes, ma'am. Patient known case of insulin-dependent diabetes mellitus presented with decay, potassium 6 millimole per liter, and blood sugar 350 milligram per deciliter. What will you give? 350 is okay. It's maybe 19 millimole per liter. Then what will you give him? Okay, I will give IV fluid. Initially IV fluid, but yeah, nothing to say that it's initial or appropriate. I will go for IV fluid. Potassium 6. I
Dr.
fluid and
Badhon,
insulin.
okay. Dr. Badhon, is insulin dependent diabetes mellitus means what?
Type 2 diabetes mellitus.
It's a decay. No, insulin dependent, my dear.
Okay.
Insulin dependent means
Oh,
type
okay, okay.
1.
Type 1. Oh,
Type
yeah,
1.
type 1.
Honk is
Okay.
type 2. So potassium 6, blood sugar high.
Yes.
It's a decay. I already discussed this question. So how you will manage?
Okay, ma'am. Can I try, ma'am? Kishori, I'm here. Okay, ma'am, I think the best way to determine this by giving sodium bicarbonate. Ma'am, can you
First
hear
of
me?
all, yeah, I can hear you. First of all, Dr. Kishori and Dr. Badhon, for both, it's a clinical scenario. Insulin dependent decay hyperkalemia. First of all, insulin itself cause decreased potassium by sodium potassium exchange transfer. So I have to ensure insulin first. Because patient on decay, hyperglycemia, hyperkalemia, patient will go to the cardiac arrest. I have to ensure hypokalemia first by giving insulin. And patient in decay, I have to manage by fluid also. Sodium bicarbonate, no role right now. Okay, clear?
Okay, ma'am.
Yes.
It's a really very important exam question. Just basically, I want to again review few points. Just
Ma'am, I have read
Hi, ma'am. Can I ask a question?
It's Reza, right?
Yeah. Yes.
Yeah. Yeah.
In this case, I think option A and option B also together are right. But I think option B is more complete than option A. I will choose option B because IV fluid and insulin altogether needs for this case, I think.
Yeah, answer option B. First of all, yeah, Dr. Reza, thank you.
Welcome.
First of all, yeah, thank you. First of all, my dear candidates, very important exam question. Just remember, if potassium is not here, I will manage by fluid first. This question I just discussed. Here, potassium given means patient is goes towards the cardiac hyperkalemia arrhythmia. So I have to manage also this potassium level by giving IV insulin. So for this patient, fluid cross. Sodium bicarbonate cross, because there's no rule of sodium bicarbonate because there's nothing. So we have to manage this patient by fluid and insulin. So DKA management already discussed that this categories ketone body, pH value, bicarbonate value. So Dr. Kishori, you must strongly remember this way that bicarbonate value below 15, we can give bicarb, only bicarb to reverse the acidosis, but it is not our headache actually. Our headache is that potassium and glucose. So we have to, though these are the diagnostic category, ketone body above 3, this blood glucose analysis, pH value below 7.3, ketone, where everything is the very important. But for our management, because question from the management, I have to very strongly, I'm telling for my every candidate, don't do mismatch, don't do wrong kindly. Initially fluid, but if they give potassium level, we have to manage by insulin. So see, I already discussed this. So complication cerebral edema, they can give this confusion level. So we have to remember this way. So see, these are the question they ask. Type 1 diabetes mellitus, thirsty, confused, abdominal pain, ketonuria in the urine. So what you will do? We have to do the blood gas. Then we have to start the normal saline. Very this PDF must read every candidate. So this maturity onset diabetes mellitus, those not so high topics for the exam, just for remember that a 25-year-old with polyuria polydipsia presence with GP surgery, HB1C level 60, fasting level below 7. So what is the diagnosis? Diagnosis is MODI. So MODI is managed by secondary care. We have to be careful. So regarding the MODI, suspected management is maturity onset type 1 diabetes mellitus. So it's referral not an option. Sulfonylurea we can give. Okay, MODI management we can give sulfonylurea. Latent autoimmune diabetes, just we discussed that 18 to 25, the age value we already, though it is a type 2 diabetes mellitus and age value is very important. It's the develop in adulthood 35. It's not adult, elderly patient, it's a 35 only. So adulthood. So see, maturity onset below 25 and latent autoimmune diabetes adulthood is that 30 to 50 years. So when patient come to your hospital 55 years old, it's an insulin resistant type 2 diabetes mellitus. Stress hyperglycemia, just I discussed this question. Just I discussed this question with that. I mean, it may be Dr. Kishore that stress hyperglycemia, see, raised blood sugar level after infection, stress, trauma, surgery. Okay, cause stress hyperglycemia, normal stress reaction. Blood test performs is resolved spontaneously within hour. So the question first one I discussed with Dr. Kishori with. So it was persistent. So it's not stress related. Okay. Glycosuria means it's also we can found in the stress related hyperglycemia patient. Pre-diabetes, we already discussed the level. Hyperprolactinemia, very important exam question. Prolactinoma is the cause. The drug risperidone, haloperidol is the cause, brain injury is the cause, hypothyroidism. But exam they ask prolactinoma. Presentation, this FSH, LH, all will be the inhibit, means patient come to your hospital with amenorrhea, galactorrhea, and in male patient hypogonadism, libido, that's the erectile dysfunction, reduced libido, gynecomastia, erectile dysfunction, visual dysfunction, bitemporal hemanopia. My heart candidates, they give this scenario, just remember this way. This hyperprolactinemia management always surgery. So hyperprolactinemia, remember we have to do serum prolactin level, pituitary MRI, visual field will be testing. The treatment surgery, dopamine agonist, cabergoline, bromocriptine, medical management, and radiotherapy if needed. Just remember surgery. If they ask medical management, it's bromocriptine or cabergoline. So thyroid question, though we know the clinical presentation, this palpitation, diarrhea, irritability, oligomenorrhea, all goes towards the hyperthyroidism. In hypothyroidism, menstrual irregularity, menorrhagia, bradycardia, constipation, all goes towards the hypothyroidism. But question they asked by the management. So these are the lab value. Hyperthyroidism always grapes. Its antimicrobial antibody will be the positive, or anti-TP will be the positive. Anti-thyroglobulin will be the positive. Toxic nodular goiter will be the positive. Decorbon thyroiditis will be present. These are the way they present it commonly. In hypothyroidism, it could be the iodine deficiency, autoimmune Hashimoto thyroiditis. Secondary, it could be the hypopituitarism. So causology very important. Is it autoimmune? Is it drug related, or it is postpartum, or it's a infective? So hypothyroidism we always manage by thyroxine. Hyperthyroidism, antithyroid drug, carbimazole, propylthyrosol, radioiodine therapy if needed, or thyroidectomy, hyperthyroidism. So these are the lab value we know very well. Very importantly, remember subclinical hypothyroidism, TSH will be the high, but subclinical hyperthyroidism, TSH will be the low. Subclinical hypothyroidism, so remember that in subclinical hypothyroidism, TSH is high. So TSH is high, but T4 within normal. Okay, it's just opposite. So it represents, and we have to do blood test 3 months. So if TSH is raised above 10, consider levothyroxine. If above 10, if below 10, if symptomatic age below 65, we can give levothyroxine. This chart must remember in subclinical hypothyroidism TSH value, and when we consider levothyroxine if TSH value more than 10. Hyperthyroidism in pregnancy management, they ask commonly in the exam. Pre-pregnancy first trimester, propylthyrosol. Second, third trimester, carbimazole, partial thyroidectomy if needed in second trimester. If carbimazole is not, if it is no need to remember, just remember second and third trimester carbimazole. We can do in second trimester partial thyroidectomy. This means if patient pregnant with post with propylthyrosol in her first trimester, she should switch to the carbimazole in the second trimester. It's a very high yield exam question, very important. Okay, my DHA candidate, my every candidate, this very important. First trimester propylthyrosol and second trimester carbimazole if it is not controlled. Lowest possible, so notes in pregnancy that block replacement therapy not suitable. Radioarthritis is the contraindicated in pregnancy. So this one already discussed. So this question will be discussed with me. First question, Dr. Saba. Okay, Dr. Saba, if not here, first question by Dr. Nandini Sharma.
Yes, ma'am. Ma'am, question 5. 60 years old woman presented to the physician complaining of swelling in her neck, or past medical history is significant for rheumatoid arthritis or Sjögren's syndrome. Physical examination reveals a medially nodular firm rubbery goiter. Total serum thyroxine T4 is 10 milligram per deciliter, and TSH shows a level of 1.2 milliliter unit per ml. Antithyroid peroxidase antibodies are high. Which of the following is the most likely diagnosis? A. Euthyroid 6 syndrome. B. Graves' disease. Number C. Hashimoto thyroiditis. And D. Silent lymphatic thyroiditis. Um, Ma'am, in his history, he is having a rheumatoid arthritis and Sjögren's syndrome as well, and he is presented with medially nodular firm rubbery goiter. So the diagnosis is, ma'am, euthyroid
Very,
6 syndrome.
very important exam question. Okay, Dr. Saba,
Yes, yes, ma'am.
read this question.
Ma'am, again read, ma'am.
Yeah, again read.
A 60 years old woman present to a physician complaining of a swelling in her neck. Her past medical history is significant for rheumatoid arthritis and Sjögren's syndrome. Ma'am, actually, the screen is disappeared now.
Now,
Physical examination reveals medially nodular, firm, rubbery goiter. Total serum thyroxine T4 is 10 milligram per deciliter, and TSH shows a level of 1.2. Antithyroid peroxidase antibodies are high. Which of the following is most likely diagnosis? Ma'am,
first of all, Dr. Saba, tell me what is the background. Patient is what? Patient is
patient is
autoimmune
already having a rheumatoid arthritis and Sjögren's
and
syndrome,
jaundice. So it's the
and he is
autoimmune.
on
The auto.
these are both are autoimmune diseases, and he is also having a multinodular goiter in his neck, which is nodular, rubbery, and firm. And her labs are thyroxine is high. So the ma'am, it is ma'am, answer is
First of all, what is the interpretation? Serum.
Ma'am, can I say this answer of this question?
Yeah. All
I am
I'll
Dr.
discuss.
Kutsi.
One. Yeah.
Ma'am, the point which I mark is anti-peroxidase antibodies is also high. It usually high in Hashimoto thyroiditis.
Dr. Saba.
yes, ma'am.
What is the answer?
Ma'am, it's C, because
C. Hashimoto
Hashimoto
thyroiditis.
thyroiditis is also immune disease, autoimmune disease.
NT-TPO, Dr. Kutsi, NT-TPO, NT-TSH, NT-TSH, today's
Right.
antibody is positive. So NT-TPO for what and NT-TSH receptor antibody for what? Dr. Kutsi. TSH receptor antibody for what?
For Graves' disease.
Yes, ma'am.
Excellent. TSH receptor antibody for Graves, TPO only for
Hashimoto thyroiditis.
Hashimoto. Already I discussed this.
Also
All
called
I
silent
discussed.
thyroiditis.
It's autoimmune on. It's autoimmune. Is nice scenario. Nice scenario. If I say, if I back to words, just remember the chart. So see, hypothyroidism, autoimmune, Hashimoto's thyroiditis. So patient RA, Sjogren, all are the autoimmune. Okay. In
Yes,
grapes,
ma'am.
antimicrobial antibody, I say anti-TSS receptor antibody or anti-thyroglobulin antibody positive. This antibody against, it's antibody against thyroid peroxide is hyperthyroidism. It could be present, but remember anti-TPO only for the hypothyroidism or Hashimoto's. Cause the strong clue patient autoimmune.
Yes, ma'am. So the answer is, ma'am, C, Hashimoto thyroiditis.
Yes, the answer is C. First of all, patient's T4 TSS level is normal, but TPO is higher, so it goes towards it's a Hashimoto's thyroiditis. Clear?
Yes, ma'am. Clear.
Yeah. Doctor, it's a Nandini, clear? Clear, Doctor Nandini. I was discussing this question with you, I think.
No, ma'am. I was not discussing this question. Actually, you were discussing the question with Dr. Saba.
No, first, you read this question first.
No, ma'am, I didn't.
Oh, okay, okay. Who before Saba, who was talking with me? Before Saba, this question. Okay. So second question. Okay, thank you, Dr. Nandini. So second question will be discussed by Dr. Reza, sorry.
Hi, ma'am.
Yeah.
Female patient with hypothyroidism on thyroxine, she checked by her own TSH, which is high, not measure T4, T3 and T4. What will you do? Hypothyroidism and receive thyroxine, check her own TSH, which is high. And then I think the drug is not enough because when the patient receive thyroxine, it must be normal level. Then the drug thyroxine is not enough, but not measured T3 or T4. What will you do? Increase thyroxine for follow after 6 months, increase thyroxine follow after 3 months, then A or B, because we must increase the drug. Then I think the better is increase thyroxine follow up after 3 months.
Excellent. First 3 months. Okay. Excellent.
Yes.
We have to do in just 3 months. Okay. Thank you. Thank you, doctor. So you done well. All doctors done well and tried based though question very important or the exam question. So thyroid crisis we managed by thyroid storm exam question by propyl thyroid cell and palpitation. Patient come, we have to give beta blocker. If infective etiology, we have to give IV antibiotic. Like this thyroid crisis due to the infection or any other disease, so we have to manage accordingly. Postpartum thyroiditis, patient after birth, patient develop hypothyroid status, so we have to give this palpitation and patient present with palpitation, we have to give beta blocker. Postpartum thyroiditis question, very common question for the exam. Okay. I don't know. First question will be discussed by Dr. Priscilla.
Yes, ma'am.
First question.
60 years old male complain of decreased libido, decreased ejaculation, FBS 6.5, increased prolactin, normal FSH and LH. What is the next step?
First of all, Dr. Priscilla, what are the presentation? Patient complaining of decreased libido. Just a few minutes ago, I discussed. Decreased
So
libido, decreased
hyperprolactin.
ejaculation. So hyperprolactemia, hyper.
Yes.
So we have to do what? There is no bromocriptine, there is no cabergoline. So we have to do what?
We have to see the pituitary gland. So we are suspecting prolactinoma. So we have to do CT on the head.
City of the head. Excellent. So, and management is surgical.
Surgery.
Yeah, surgical. Thank you. Second question by Dr. Priya.
Yes, ma'am.
Yeah.
Single thyroid nodule showed high iodine uptake. What is the best treatment? Option A, radioiodine 131. B, send home. C, antithyroid medication. D, excision if present.
High iodine uptake, Dr. Priya.
Yes, ma'am. Option A, ma'am, radioiodine 131.
No. Initially, what is the best means you have to do start this patient come to your hospital, you see the nodule, there's a high uptake high, so it's a hyperthyroid state, so you have to start the medication first.
Antithyroid medication, C, ma'am. That case, yes.
Okay, best
Yes.
we have to then if fail stepwise, if fail then right therapy.
It will, yes, ma'am. Yes, I got it. Thank you.
Very important exam question. CR, ADH, very important, very important. High topics, diabetes insipidus, polyuria, polydipsia, cranial diabetes insipidus, nephrogenic diabetes insipidus. You have to remember very well. So cranial diabetes insipidus, my dear candidates, remember very well. They ask in the exam the injury of the head injury. So it's a cranial. If you can't understand, just see the topics, what they are asking. Head injury, sarcoidosis, tuberculosis, infection all goes towards the cranial. For the nephrogenic, they must give exam question lithium. Patient on psychiatry, patient taking the lithium, or patient have psychiatry, goes toward the nephrogenic diabetes insipidus. CR question very important. Any kind of small cell carcinoma patient, meningitis patient, any drug, SSRI, chloramphenicol, my dear candidates, remember this drug very well. It causes Cl, sodium inappropriate antidiuretic hormone, which plasma osmolality will be high, urine osmolality will be low. Cl, we have to give demiclocycline, tolvaptan for diabetes insipidus, desmopressin, nephrogenic diabetes insipidus, urine osmolality will be high, plasma osmolality will be low. So, hypotonic polyuria, just not so important. Polyuria, polydipsia question, diabetes insipidus. Just the serum sodium high, the osmolality will be, plasma osmolality will be high, sodium will be high, urine osmolality will be low. Just they describe this way. Cranial diabetes insipidus, nephrogenic water deprivation test if we do. So water deprivation test for the cranial diabetes insipidus below 300, but if you give desmopressin injection, it will be the more than 800. For the nephrogenic, it will be the all will be the below 300. Just remember this value. For the psychogenic polydipsia, osmolality will not be change. Urine osmolality would increase in undergoes water deprivation test. CR, already I discussed regarding the CR. It could be the any cancer in the brain, lungs, neoplastic disease. It could be the any meningitis, stroke, tumor, and a chest infection, pneumonia, tuberculosis can cause CR. CR, urine osmolality will be the high, and urine osmolality will be high, plasma osmolality will be the low. So see, there's a ping the salt in good regarding the CR. So all salt are losing. So that's why sodium will be the lower. So Cushing syndrome very high topics for the exam. It is due to the ACTH dependent or ACTH independent. So ACTH dependent, independent, we have to remember very carefully for the Cushing. Cushing could be the from the adrenal gland, from the pituitary gland. So independent, if it is adrenal adenoma, if dependent, when pituitary from the pituitary gland is secreting pituitary adenoma. So Cushing, ACTH dependent, we have to remember the pituitary, independent, we have to remember the adrenal. Excessive ACTH administration, ACTH dependent, independent, exogenous glucocorticoid administration. These are the Cushing syndrome picture. Easily visibility, purple striae, obesity, hypertension. These are the picture. Muscle wasting. We have to do confirm by 24-hour urinary free cortisol. It's the exam question. We have to confirm by 24-hour urinary free cortisol. Plasma ACTH high will be ACTH dependent. If it is low, it's ACTH independent. We have to do the MRI pituitary. If ACTH is high, we have to do CT MRI of the abdomen. If it is ACTH low, means it's independent. This question will be discussed with me, doctor. Is that Dr. Sherin John is here? Okay, Dr. Sherin
Yes,
John, if
ma'am.
not, okay. Discuss this question.
75-year-old smoker presented to his GP with cough and shortness of breath. Exam revealed pigmentation of the oral mucus and also over the palms and soles. And test shows that he is diabetic and hypokalemia. What is the most probable diagnosis? A. Pseudo-Cushing syndrome. B. Conn's disease. And C is ectopic ACTH. D is Cushing disease. And E is hypothyroidism. I mean, is it a D Cushing disease?
So, doctor, first of all, Dr. John, so see your GP complaining and patient complaining of cough, shortness of breath, right?
Yes, ma'am.
And you are seeing there is a pigmentation of oral mucosa, and there is a palmar and so also there is a pigmentation present. And you are seeing there is a hypokalemia. So you are thinking there is a ACTH are secreting ectopic, right?
Yes.
This pigmentation caused due to the ectopic. It's not Cushing. It's the ectopic ACTH due to the patient already. It's a patient case of the either cancer or small cell cancer or any infection. So we don't know whatever the cause. We have to remember that this causology, this pigmentation due to ectopic ACTH are secreting.
Yes,
Clear?
yes.
For you see hypokalemia only for addition. You know, in addition you will get the hypokalemia. So you may ask me, ma'am, where there's a weight loss, why there's a fatigue elevated, how I can understand. You have to understand because there's a smoking patient, it goes to, and age is 75, it goes towards the malignancy, small cell cancer. So we have to remember this pigmentation hypokalemia is goes towards the additions.
Yes, ma'am.
Okay, clear?
Okay. Yes, ma'am.
So see here what the presentation is, could be the acid addition or it could be ectopic acidities related. Okay, hypokalemia. So see cortisol leading to the diabetes, hypokalemia. So okay, acidities dependent pigmentation. Okay. Thank you, Dr. John. Pheochromocytoma exam question, DH question. My MOH, hard, DH, all kinds of DH question. How you will manage, what you will do. This is the question. Though management and presentation same, palpitation, sweating, anxiety, tremor, headache. But 24-hour urinary metanephrine, we have to do first test. 24-hour urinary metanephrine, then we can do this VMA test or venous medullary artery scan test. Okay, 24 urinary catecholamine test or CT scan to locate the tumor or VMA test. So this pheochromocytoma associated with multiple endocrine neoplasia, neurofibrosis, von Hippel-Inducinet. Just remember, we have to do surgical resection or we can give management panoxybenjamin. Adrenal insufficiency, already discussed shortly with Dr. John, that Addison disease, autoimmune disease, it could be an infection cause, it could be any congenital adrenal hyperplasia, any drug cause itself can cause Addison disease, but presentation hypothalamic pituitary can be caused. Acute, it could be the hypotension, shock, hypokalemia, weakness, syncope, vomiting. Actually, all they don't give. They give the hyperpigmentation picture, they give weakness picture, abdominal pain picture. So my dear candidates, remember this clue very strongly. In addition, high potassium. So you can ask me, ma'am, there's a hypokalemia. So Cushing itself cause hypokalemia. Ectopic ACTH can cause Cushing. Cortisol is releasing. But in high adrenal insufficiency, addition can cause hyperkalemia. So both can, just remember strongly, hyperkalemia goes towards the adrenal insufficiency. Low potassium can cause addition, but itself when they say this is smoking, it's a ectopic ACTH secretin, it's a Cushing. But hypokalemia, Cushing itself can cause hypokalemia. Adrenal insufficiency can cause hyperkalemia, but it can cause hypokalemia itself. But the cause of background information is not clean cut. That's why we have to remember this hyperpigmentation only is the cause for the ectopic ACTH. So adrenal insufficiency treatment is the hydrocortisone or fludrocortisone. Exam question, my DHA candidates, fludrocortisone, hydrocortisone, we have to manage. Adrenal insufficiency, so pituitary gland, and so see the adrenal gland. From the adrenal gland, they are secreting the cortisol, and from the pituitary gland, they are secreting ACTH, in which ACTH adrenal insufficiency. Okay, this way they are either they are causing the Cushing, or from if cortisol low, or if that they are cause addition if it is adrenal ACTH lowering down. Synaptin test we have to do the for the diagnosis of the adrenal insufficiency addition disease. So cortisol we have to measure if this is the Cushing, or synaptin test we have to do if it is addition to this triad. You remember hyperkalemia, hypotentemia for the addition disease. Hyperkalemia, hyponatremia, it goes towards the addition disease. So adrenal insufficiency, brain tumor, this could be the autoimmune disease. So adrenal insufficiency. So adrenal insufficiency question, if any patient adrenal insufficiency but suffering from the any fever infection, we have to doubling the dose of the hydrocortisone because it remains more increase. The exam question, they ask patient come to hospital, adrenal insufficiency, taking the hydrocortisone now. Patient suffering from the RTI or GIT problem or gastroenteritis, what you will do? You have to increase the hydrocortisone level. So primary adrenal insufficiency, addition disease presentation, salty, crabbing, hyperpigmentation, dizzy, okay, tiredness, malaise, hyponatremia, hyperkalemia, okay, the thirsty picture. So if below 100, diagnosis is very unlikely. If 100 to 140, we have to do short synaptin test. If more than 140, the short synaptin test means the addition crisis is what? If sudden onset, if you withdraw chronic steroid therapy, it causes Addisonian crisis. So patient may present it with the tachycardia, abdominal pain, hypoglycemia. We have to do the cortisol and ACTH level. And we treatment is the IV fluid initially and hydrocortisone. If hypoglycemia, we have to give this glucagon or glucose infusion. So this question one by one. First question will be discussed with me. Pallavi, Dr. Pallavi, first question.
Yes, ma'am. No, I can't see any question. Yes, ma'am. Old patient with neck swelling, nodular disfiguring with history of muscle weakness, cold intolerance, hoarseness. What is your management? Hoarseness. Nodular history of muscle weakness, cold intolerance. So hypothyroidism. Ma'am, levothyroxine. Levothyroxine.
Okay. Because patient has hypothyroid picture.
Feature, yes, ma'am.
Yeah, okay, excellent, nice done. Second question by Dr. Reza.
Hi, ma'am.
Yeah.
40 years old male presented with large hands hepatomegaly diagnosis. Hepatomegaly and large hand organomegaly and limb and hand large. It can caused by gigantis and acromegaly. Acromegaly is gigantis is before adult age and acromegaly is after adult age. Then I think it must be A.
Okay, thank you. Great, well done.
Okay.
Excellent. So fourth question, patient presented typical symptoms of hypothyroidism. This question will be answered by Dr. Monia Jaman.
Hello.
Yeah, four
Which
questions.
question? Which one? The number?
Last one. Last one.
Last one. Okay. The patient with typical symptoms of hyperthyroidism. What is the most effective and rapid way to relieve the symptoms? Hyperthyroidism. The options are propranolol, PTUE, radioactive iodine, and surgery. Is typical symptoms of hyperthyroidism, we will go with the propyl thiouracil. This is the initial management actually. And they did
No.
not tell
First
any
of
other
all,
things.
okay, if I, Dr. Monia Jaman, if I say give some clue and discuss with me, if I say this hyperthyroidism patient presented with you palpitation, so patient suffering, and you are doctor that you are telling me, ma'am, I have severe palpitation. If
Okay.
you give carbimazole or propylthyroxine, will it relieve the patient's presentation? No, because
No,
it
that
will not
beta
work.
blocker. Yeah.
So most, if it does say, doctor, just read carefully. Rapid way to relieve symptoms. Patient complaining of I have palpitation. Only these are the common picture of hyperthyroidism. So rapid way relieve symptoms mean what? Means
Propanol.
patient suffering from palpitation. So I have to
Palpitation.
relieve this
Yeah.
patient. I have to relieve rapidly. Right?
Rapidly.
Okay. Clear?
Okay. Okay. Yeah. Clear. Thank you.
So actually, question may be indirect. We have to understand the question pattern, what they are asking. Okay.
Okay.
Thank you. So hyperaldosteronism, primary hyperaldosteronism, adrenal adenoma, adrenal hyperplasia, secondary hyperaldosteronism picture. This is the renin producing tumor, renal artery stenosis, clinical picture, hypertension, hypokalemia. So just remember hyperaldosteronism picture. They ask what you will do. Renin aldosterone level we have to do initially, but for the basic or definitively we have to do the CT MRI to see the adenoma. Okay, treatment always surgical resection, but we can do initially. This exam question is spirolectomy. We can give in for the hyperaldosteronism patient. This question, first question will be discussed with me, doctor.
I put it on time.
Dr. Nipuni is here. If Dr. Nipuni is the Maha Umer, first question.
Yes, ma'am. A hypothyroid patient on thyroxine had anorexia, dry cough, and dyspnea, and left ventricular dysfunction. She had normal TSH and T4 level, hyperphosphatemia and hypocalcemia. The diagnosis: A. Primary hypoparathyroidism, B. Secondary hypoparathyroidism, C. Hypopituitarism, D. Uncontrolled hyperparathyroidism. Ma'am, hypothyroid patient on
Hyperphosphatemia, which goes towards what I already discussed.
Hyperparathyroidism.
Yeah, is it primary or secondary? Hyperphosphatemia.
Primary hyperphosphatemia in secondary.
Secondary. It's a secondary.
In CKD patient. Yes,
yeah,
ma'am.
it's a secondary. Okay, thank you.
Okay.
So thank you. Second question will be discussed with me, Dr. Kishori. Second question. Is Dr. Kishori if not
Okay,
here?
I'm here.
Yeah.
Okay, 20-year-old healthy man was diagnosed to have medullary cancer of the thyroid. The patient was also noted to have hyperplasia of the parathyroid gland. The patient must now be investigated for
the possibility of what?
I think that it's possibility of Hodgkin's lymphoma, ma'am.
No. First of all, Dr. Kishore, this is not easy. It's indirect question. Sometimes
Okay,
you have to
ma'am.
face
Can I
to
try?
okay.
Okay.
Yeah, okay. You
Okay.
have to try, but see what are the glands already shortly discussed in my primary set. Initially I just discussed, but this is severely indirect question. Just remember these are the effect, and this I am thinking. This is not direct question. Okay, think.
I think she already have hyperplasia of the parathyroid gland, and the patient is diagnosed with medullary cancer of the thyroid. Hodgkin's is not possible. Malignant melanoma, I don't think it's between pheochromocytoma, but it's the pheochromocytoma. Is it pheochromocytoma, ma'am?
Okay, excellent. Your answer correct. But can you tell me in white pheochromocytoma we have to think? Cause why?
I think in pheochromocytoma, but there is no mention of hypertension, right? Hypertension is not mentioned.
Okay. Okay, I'm discussing. First of all, patient have medullary cancer of the thyroid, hyperplasia of the parathyroid. I discussed if
is it
thyroid
meant to? Okay, sorry, meant to, right? Yes.
Okay, okay, it's a meant to. It's a meant. It's an indeed question. Okay, there's
Yeah,
nothing, but
pheochromocytoma is
we have
part
to
of meant to.
investigate. Yes, so we have to investigate for the pheochromocytoma. It's the main two. Signs
Yes.
symptoms related to the multiple endocrine neoplasia type 2B. Okay, clear, Dr.
Yes,
Kishori?
yes.
Question is not
Yes,
clear.
ma'am.
Okay. Okay, thank you. Thank you, Dr. Kishori. She has, very important exam question: absence of lactation, amenorrhea, hypothyroidism, adrenal insufficiency, low TSST4, low ACT is very important exam question. Pituitary hypoplasia, pituitary tumor can present. Patient is presented with headache, visual problem, visual field defect. So we have to assess the hormone. The Sheehan tumor question very important. There's lots of they ask the causology. Causology actually due to the severe bleeding, interpartum, postpartum hemorrhage, pituitary necrosis of the pituitary gland. So she has seen a very important exam question. Amenorrhea. It could be the constitutional delay, it could be the hypothalamic failure, it is the Coleman syndrome. Secondary cause, it could be the pregnancy, menopause, premature over. This is the causology, but we have to remain investigate by the FSH, LH value, PCOS value. My dear, every candidate after posting this PDF must read the Sheehan amenorrhea must. When we have to give the hormone replacement therapy for the ovarian failure because we have to manage by the insulin sensitivity, increase the metformin or decrease the weight, hyperprolactinemia, we can give the surgical resection. This way we have to think. Amenorrhea question very high topics for the exam. These are the value I already charted here. Just remember strongly. Acromegaly I discussed with Dr. Reza already. So this acromegaly, increased growth hormone, enlargement of the hand, feet, frontal bossy, macroglossal, prognostism, coarse facial. Thus we have to remember this oral glucose tolerance test will be the higher to confirm it. Octreated we can give, GS receptor antagonist, pegmesomate we can give rather than radiotherapy and later. Metabolic acidosis, alkalosis, my both question was on my exam. Okay, metabolic acidosis, never forget. This ketoacidosis associated starvation, associated diabetes mellitus, this associated diarrhea. They ask many questions from the metabolic acidosis, respiratory acidosis, metabolic alkalosis. Just remember blindly if diarrhea present is acidosis. Respiratory compensation by hyperventilation, renal compensation by bicarbonate. That's it. Just remember if pH value below 7.35, bicarbonate below 22, it's a metabolic acidosis. Metabolic alkalosis exam question. pH more than 7.5, they give this pH value, vomiting. It's both way I face my exam. Many candidates are facing every day. Hyperaldosteronism, hyperkalemia, all goes toward the alkalosis. We have to do the respiratory concentration for the alkalosis or acidosis. So respiratory acidosis, alkalosis, I already discussed. My emergency question PDF I will discuss tomorrow, inshallah. Just acidosis, remember COPD, asthma, and obesity, hyperventilation, and alkalosis along with the pulmonary embolism or panic attack. And hyperventilation associated with the carbon dioxide below 35 millimeter. Hyperpituitarism question, very important exam question. I already discussed shortly. Pituitary adenoma, mostly common cause is the LHFS growth hormone. All will be the lower. This is the hyperpituitarism. So last question will be discussed. My question today, my discussion already ended. So last question will be discussed with my last question. This is the last question by Dr. Renata. Can try.
Hypertension, history of muscle weakness, family history of early hypertension, cerebrovascular event at age less than 40 years. On lab, spontaneously hypokalemia, suspected primary hyperaldosteronism, which test confirmed the diagnosis. First, aldosterone creatinine ratio, aldosterone renin ratio, aldosterone 24 hours monitoring, none of above.
So it's a primary hyperaldosteronism, Dr. Renata. It's a primary hyperaldosteronism. So what we do, already discussed these topics.
I'm thinking about between A and C. Maybe
No.
A?
It's
No.
not A, it's not C. Because primary hyperaldosteronism, we have to do what?
Renin test, plasma renin.
Renin test,
Always,
plasma
yes,
renin
always
test.
low. The
Always,
renin
always
low.
aldosterone renin test we have to do. Dr. Renita, clear? Always primary hyperaldosteronism we have to do aldosterone renin ratio in which renin low will be found low. Clear?
Yes. Yes, thank you.
So we have to do aldosterone renin ratio. Thank you, my dear candidates. Today my endocrine session ended and the mock question will be posted soon and this PDF will be posted soon. Though the session will be time need for downloading. So thank you, my dear candidates. Keep practice, keep focus on those notes. All will be posted and soon, inshallah, and mock will be posted. Assalamu alaikum, my dear candidates. Thank you, my dear candidates.
Thank you, ma'am.
Thank you, ma'am.